They can't find it.
And we're live. Hi, everybody. I
Hi.
am Dr. Stephen Phillips here with
Hi.
Dana.
I'm fake Dr. Dana Parrish. My parents just called right as we were about to go live. And I just want to make sure that I hope they're on. I mean, they get so upset if they miss these things. So my mom can't criticize the way I look. She can't tell me how long my hair is and how cute you look. That just bums her out when she can't give the full court press on her opinions.
So I'm just getting a message here. Do you see that, Dana? That says we're having trouble streaming to your destination. I think it's about Instagram. So I don't know because it goes to a bunch of destinations at one time. So do you happen? Can you see on your Facebook if we're showing up in the proper places?
Like it is. It looks like we're live. Guys, are we?
So do you happen?
Can anybody tell us on Facebook if they can see us? It looks like we're live because I want to answer some questions.
Okay. I don't see any questions coming up, but we can just chat like we do.
I see some questions coming up on Facebook that people posted from before.
Okay, that sounds great.
Hopefully it works. Hopefully we can
here's some people. Yes. Okay. I think there's a bit of a delay, that's all. We see Linda Marie and Michelle Rizzuto Therer, and sorry if I pronounced Palmer. Sorry if I pronounce anyone's names incorrectly. That's the thing with my name, Phillips. I always make a thing to say when people customer service people, when I say Phillips, I'm like, it's Phillips, pronounced Phillips, just to make it, because it's such a boring name.
I think you had a really easy time with Palmer just now.
Well,
you can handle Palmer.
Yeah.
So there's so many things. So you and I are so behind on our public commentary on the state of affairs, the state of the world, the state of COVID, the state of Lyme. Our paperback just came out. We haven't even. We've been so slammed, and we've been doing all this press kind of under radio tours and things they're in little towns. So we don't do a big full court press, but we just need to start posting some links. We're two of us are crazed right now.
I can't even keep up with activities of daily living. Like what I just said before, I have to move because there's too much paperwork in my house. Who does that? No one moves because they can't clean their house from paperwork.
Well, you've got good reasons to move. You've got a great new place to move to. And if it's okay, let's just share that we updated the paperback with the COVID chapter, various other things. The COVID chapter is in there, and not to be cocky or anything, but pretty much everything we predicted with COVID happened with COVID. Literally, there's nothing that we had to pull because we were like, yikes, that was really embarrassing and off.
And I don't remember if we actually said this publicly, but I just want to say it for everybody, just so they know. I've told this to my patients many times. So we had interviewed so many people for the COVID chapter, and not all the interviews, that we made it to the book, but we had so many people telling us that COVID was made in a lab back then. That was when it first came out. Nobody would go on record, and we couldn't include that in the book. And
one line. You wrote one really crafty line in the COVID chapter that kind of intimated it, but we were careful because, first of all, at that time, you were getting kicked off of social media for even suggesting it. All my posts when I would
not me personally, a person was.
No, everybody. No,
yeah.
Not you.
But what I'm saying is, how messed up is the situation that you have to wait a year and a half until it's okay to talk about something which everyone knew a year and a half before. And I feel like we were forced into doing a disservice by, I wanted to go forward with, full court press, truth. It's like our motto.
Right.
But we were very much constrained and were unable to talk about these things publicly that everybody knew early on. And now you're not considered tinfoil hat if you talk about it, but back then we would have been. So, we couldn't do it because of
Well, I think we may have talked about it on our Facebook Lives, and I know we did some posts about it, but a lot of them got sort of censored. There was a fact check, and then all of it got removed. All those fact checkers, all those things, a lot of them got lifted because it ended up being true. And what's crazy is what we talked about yesterday, like gain of function research, which is research that is taking a pathogen and making it more virulent or more transmissible, so more dangerous or more transmissible in a lab. It's pretty easy to do. Lots of scientists do it now. And it's still being done in the era of COVID. And, there was a big call to stop this.
I just tweeted about that. I said, just the fact that this is still going on, there's enough said, basically. Like, what I say? Something like, if it weren't for maniacal sociopaths ruling the world, gain of function would have been banned globally.
Right.
I guess that's not going to happen. So the fact that it's still going on despite everything, and despite the fact that there's not been a single scientific advance, I challenge anyone to point out any, life-changing or even considerable scientific advance from gain of function research. Right. The only thing we've done is decimated our species in irrevocable ways and gone through tears of hell. And
yeah, exactly. We don't even have to talk about the other, this is just one pathogen that's been potentially, lab created, lab enhanced. We have a long history of doing these kinds of things. And I refer you to Chris Newby's fantastic book, Bitten.
Yeah, Bitten.
For more and for a really well documented history of, gain of function research and many other things. It's very disturbing. But,
it's so disturbing. I just think we have to mature as a species. But, in terms of other stuff to go over, we definitely want to get to questions. We can talk all day about just the stuff that we always just talk about for hours and hours and hours. But I always feel bad that we can never address the questions that people have because they're good questions.
I have great questions lined up. Should I just start rolling them off to you?
Yeah, why not? I mean, I think I'd like to, because I always feel bad at the end because we're like chat, and then it's like, there's not that much time left for the questions.
That's because we never talk, that's because we never talk in private. This is like the only time we talk.
Right. It's the only time I talked. I didn't talk to you just 15 minutes ago for like an hour.
Or a few minutes before that, or this morning. Yeah. Okay. So let's just start. Okay. Will we be discussing treatment for long COVID? That's from Tamara Zablocki.
Yeah, why don't we? I mean, we should.
That's like our primo concern right now. Other than, of course, always we're worried so much about Lyme, but now the COVID is being thrown in the mix on top of people that already had Lyme plus. What are some of the treatments? Are you treating long COVID?
So as I've said many times, my personal patients, I treat about 300 patients with COVID, and I have one patient who developed long COVID despite treatments that I gave. The treatments were not given early on. She came to see me 5.5 days in. She also has a genetic immune disorder, and she did require some oxygen, some steroids, and then slowly healed from her chronic symptoms for a long period of time. And then, it's been a very difficult situation for her. But among my other, patients that I treated early, none of them developed long COVID. We had one patient who the character of her Bartonella markedly changed. Like, it was during Alpha, and I treated her with the usual stuff that I treat with, and she had a very mild case, and despite this mild case, developed a real change in all her symptoms. She had a lot of neuropathic symptoms, but they changed in character and felt that they were really materially different. So we're going after, the thought was that persistence of the virus, and we're giving a lot of different things, and we couldn't really budge her symptoms. And then when I gave her a Bactrim, which can work against Bartonella, all those symptoms which we were attributing to long COVID flared up really badly during Herxheimer. And we're like, holy moly, this is really Bartonella that's been changed by the presence of COVID. It's like I said, in other interviews and stuff, that before COVID came along, I've had a lot of patients come in. You see this in the ME/CFS kind of community where people will have a history of a viral illness, and then all hell breaks loose, and they're chronically ill after that. And I'm not saying that viruses don't persist. Like, there's all these stereotypes about everything, and stereotypes almost inevitably lead us in this wrong, very narrow direction. Yep. And those things are very black and white when they're definitely shades of gray. So we know there's evidence that the virus that causes COVID persists much longer than people realize.
That's a really important thing to say. Really important.
Right. It's been demonstrated in autopsy studies and olfactory bulb studies and GI samplings and blah, blah, blah.
Can we talk a little bit more? Sorry I just want to break it down, because this is like the thing that everybody's missing is the fact that there is a subset of people, I don't know how large or small, the data ranges, that seem to have a chronic virus, chronic COVID going on. They're finding it in organs when they do autopsies, and they're finding it in the GI tract. So can we just talk a little about the implications of that before we move on? The overlap with Lyme, all those kind of things.
Maybe it's everybody. You know, they're not doing biopsies on everyone. For people who recovered, maybe they are. You know, the parallels to other chronic infections are kind of, you know, they're eerie. So even with regular seasonal coronaviruses, there's evidence that they found these in brain specimens of people who were not, acutely suffering from coronavirus. And so when I look at when I think about long COVID, my nurse practitioners are seeing some long COVID patients. I'm not. You know, we have different practices. I have 3 nurse practitioners now. They're all doing amazing, and they've seen some long COVID patients, but they're coming to the office as new patients. Like I said, none of the patients that we've actively treated, and we haven't accepted patients just because the office is so busy. We haven't accepted like acute COVID patients. So people are calling to get an appointment and they have COVID and they have to be treated that day. We're not the best place for that because we can't get people in that day. We can try our best, but even trying our best, I mean, like moving things around and everything else is still going to be a couple of weeks no matter what, you know, so that's way too late for a COVID person. So for acute COVID, we're not the place, but we have seen some long COVID, and some of these patients have had evidence for reactivated chronic infections, like what we call Lyme plus, and some of these patients have gotten better with antimicrobial therapy. But there's a few different categories. You know, the people that have really bad, cases of what appears to be, coagulopathy going on, like elevated D dimers, which is a clotting parameter, and things like this. It's important to repopulate the lining of blood vessels. You know, we talked to Dr. Will Lee, and he was saying how drinking black tea and cocoa, chocolate, will stimulate stem cells to migrate from the bone marrow and actually regrow and repopulate the lining of blood vessels. The other thing that I'm looking into now, because it has so many implications in a lot of fields, is actually it's just over-the-counter chondroitin sulfate. It's a little premature to comment too much, but I've done a few tweets about it because they really are fascinating. Because it's used primarily for osteoarthritis, and it's part of the lining that makes blood vessels slippery. And it also has a lot of functions within the brain, and there's many different types of chondroitin. They're not all the same. They have different lengths, and they're different chemical structures, and they behave differently in the body.
Okay.
So I'm just starting to investigate that, but I'm wondering if something like this can be helpful. Again, I can't give any specifics because I'm early on in the investigation of looking through this, but I'm wondering if something like this can also help smooth out and help repair damaged endothelium, the lining of blood vessels.
What about, so can we just talk for a minute before we dive even more deeply into long COVID about acute COVID? Because I get a real lot, I know you do too, of desperate panic messages from people who get COVID. Right now, what I'm seeing, and I of course want to hear your insights, I'm seeing that people are slowly being able to get Paxlovid, which is the Pfizer drug, which is supposed to be good. And I'm not saying there are not alternatives that are also good, but I am hearing good feedback from the medical community and also from patients. I actually know somebody who's taking it now, and her symptoms dramatically reduced in about 18 hours. Now and then we also have monoclonal antibodies, which we like because they have a long life. Some of them, they can keep you protected for a while, and for immune suppressed patients, they're giving them prophylactically. What are your thoughts about some of these early treatments? And then we also have the other protocols, the things that are published that not we're allowed to talk about, but there's even things like fluvoxamine. 60 Minutes did a big piece on it about an entire year ago, and what an incredible mortality benefit it conferred, and yet still not being wholly recommended by IDSA and NIH.
Right. So listen, these early treatment interventions, in my opinion, clearly work, and not just to reduce mortality and hospitalization, they clearly work, in my experience, the experience of many other doctors I've spoken to prevent long COVID. Like after treating, I know 300 patients isn't all the patients in the world. Look, I've treated over 20,000, chronic illness patients with vector-borne diseases. So it's a drop in the bucket compared to what I've done in the kind of like the Lyme Plus world. Yeah. But still, statistically, 30% of these people should develop long COVID, and they didn't. So I do think that early treatment is absolutely key. And I think that even with mild cases, I advise my patients to seek early treatment options. And because, we can have young people who are 24 years old and healthy who have mild cases of COVID, then develop, long-term damage. And again, but to get back to the original question of how to treat COVID, I think it really is a little bit of investigation has to go on to say, okay, what is the primary cause of long COVID? I think it's a heterogeneous group is what I'm saying. I don't think it's all the same. I don't think it's all reactivated infection. I don't think it's all damage to endothelium that's really, really bad. But I think there's a mixture going on. I'm seeing D-dimers in patients who had young people that are healthy. They should not have elevated D-dimers who are having these post-COVID coagulopathy problems. And these are not patients that I've treated. Like I have not seen elevated D-dimers. I have to go back and think, but I have not seen elevated D-dimers, unless I'm misremembering one, but I don't remember seeing them in my patients who've been treated. But I have seen them in a number of patients who've not been treated early and didn't call the office. So
I'm disturbed that there's a real lack of awareness, and this is not people's fault. It's really the fault of our, federal officials who have not messaged appropriately and accurately, and the media who has complied with their, not done their job and actually done any research. So one thing that is so important for us to point out is that an initial asymptomatic or mild case, can have a latency period between when that acute illness or even that mild or even asymptomatic infection begins. So you can have a couple of weeks where you feel sort of off or whatever, and then you feel fine. 3 months later, all hell breaks loose. Sound familiar? That is what a ton of people that I hear from, and you look on the Survivor Corps website and message boards and all the long COVID boards, this is extremely common. Young, healthy people, kids, tons of athletes. I remember when we interviewed Diana Barrett, she said one of the biggest predictors of long COVID is mild or an asymptomatic illness. That was surprising. Also, people who are vaccinated, triple vaccinated, still a very, very high rate. Right now, there's data, again, ranges from that the vaccines don't confer long COVID benefit to they confer about a 50% benefit. Still, those are terrible odds, in my opinion. So
I think the people that are having this latency period have to be more suspicious of reactivated infections, rather than, it's like the people that have the really bad cases and they're just slowly kind of healing, but have these endothelial damage.
Okay. Yeah. I'm scared by what I'm seeing. I saw a case today of a 31-year-old with Alzheimer's, new onset, who had a super mild case. And
there has to be investigated, like, is there, because Alzheimer's is basically a post-mortem diagnosis in many cases, unless they do. What's that?
Dementia.
You can do spinal taps and look for biomarkers now, and you can do certain types of advanced, radionuclear tests to try and figure these out. But I do think we should talk about fluvoxamine for a second, because when you say the media doesn't do their job, I wouldn't even give them that much credit. They're doing the opposite of their job. They're actively obfuscating and preventing people from knowing the truth, and it's shameful, really. I always like to put like a nice happy bent on things. Like, I am so disgusted every time I watch certain programs that I have to turn them off. But if everybody's not familiar with fluvoxamine, there's been a couple of randomized controlled trials. The last of it was together.
Can you just talk about what it is? It's old.
Sure. Fluvoxamine is an old, cheap antidepressant drug. It has, it's generally a safe drug. It's not associated with major scary side effects, but it is associated with a lot of side effects. So it can definitely increase jitteriness and anxiety and all antidepressants can increase suicidality, especially in young people, teenagers specifically. And, but, like I said, it's generally considered a safe drug. And they had this randomized controlled trial, which was funded by very mainstream organizations, completely not at all, controversial in any way. And they set these parameters that were like, they set their limits before the study was started. And they said, if it performs below this level, then we have to stop the study early because we can't possibly use it as treatment because we know it doesn't work. And if it performs better than this upper limit of our wildest dreams, then we have to stop the study early because it would be unethical to withhold it from the placebo group because it works so well. And it performed above the preset limit. So it reduced mortality by over 90%. And they stopped the study early, and they had to, by ethical standards, offer it to the placebo group. And I have spoken to COVID patient after COVID patient after COVID patient, and I used to start out the thing by saying, well, I'm sure by now you've heard of fluvoxamine, and the usual response is, what's that?
Right.
And like this, it's not on the news.
It's really our design. It's very upsetting that we're 2 years in and we have no really widely available, widely accepted, NIH endorsed early treatments. Everything cheap and generic except for aspirin and steroids, because it was so undeniable that dexamethasone was helpful across the board.
Yeah, that's still even being underdosed though.
Everything has been discredited. And I mean, whatever, we've talked about this so much. I want to give some helpful information. So Steve, day one, somebody comes to you. They have, I know you're not treating a lot of acute COVID, but let's just give people.
But no, my patients who have COVID, my established patients who,
great. So day one, what do we do? What's the thing to do?
So I even though sotrovimab doesn't work for, the second variant quite as well as the first one, there's something like a 27 times reduction of efficacy. The pharmacokinetics are such that with the peak dosing of sotrovimab, it still goes way above the efficacy threshold. Like there was some blur about like, oh no, sotrovimab doesn't work for this other variant.
Okay.
It still works. It just doesn't work as well. I mean, it was working phenomenally well. But even them, just to say, all these things that work as an antiviral phase have to be given early. And even though for monoclonals, people, some places will give them out to 10 days, other places cap it at 7 days. I am not seeing these really, really amazing responses unless people get them right away. We're talking, I prefer by the second day, if possible. I mean, I really encourage people to be aware to do this home antigen testing if there's any sniffle and to get early treatment. So
can we also talk about that? I'm so sorry. I don't want to miss that moment. When you're swabbing yourself now with the rapid antigen, you should also swab your throat and your cheek. They've been doing this in Israel for a long time. We are always.
It's hard to swab your own throat. I tell a lot of my patients to get a good hock and phlegm on that thing, and then just to put it, before they stick it in the.
Okay. Well, if you can swab your throat, if you can't, whatever it works, you can also swab the inside of your cheek and each nostril.
Right. And the reason is because sometimes with Omicron, there's differential kinetics on where it's growing. It doesn't seem to just always grow in the nose as reliably.
Yeah.
But better to get multiple samples in the test to improve the accuracy of the test. But I still use these drugs that doctors have they've demonized. I still use ivermectin. I think that with over 70 studies showing that there's benefits. There's a recent JAMA study, which was a small study, and there were something like 3 people in the ivermectin group died, and 10 people in the standard of care group died. So a 70% mortality reduction, but it wasn't statistically significant because the study was too small. Keep in mind that when things like Paxlovid are studied, we're talking like these drug companies, they have thousands and thousands of thousands, they have these mega studies. And, to have these small studies that lack power, 70% mortality reduction for that one wasn't enough to be considered statistically significant. It may have had to have been like a 90% reduction in mortality. the thing is that none of these early treatment options are panaceas. I've definitely seen patients who've not done well on ivermectin. I've definitely seen patients where it's been almost miraculous. I don't want to ever paint a picture like, hey, this is the answer and it's 2 cents and you can get it over the counter. It's all a big conspiracy theory. What I do want to say is that the drug is helpful for many, many patients, that it is kind of still a conspiracy theory, that they have demonized these things. And I do think it's all about money, but I wouldn't put my eggs in any one basket because the heterogeneity among these patients is really vast. And so when I treat patients, I treat them with a multimodal approach and I throw the kitchen sink at them. And I do that because I want them to do well. And thus far, knock wood, they have. Keep in mind, my patients are high risk. Like every one of my practice is high risk. It's just the way it is. You know, they were coming to me with chronic illness. That puts them at a level that's going to be, you know, in large part higher than the general public. And then we have many patients with traditional high risk factors like obesity and hypertension and lung problems and things like this. What's the kitchen sink? So we have a whole list of supplements that we send out to folks, and there are many, many things on that list, including things that everyone knows about, like vitamin D recommendations, for example, are patient specific because, again, we're treating patients who are already in the practice. We keep very close tabs on vitamin D levels. We're checking them every few months. So if someone doesn't know their vitamin D status, it's a different story. Like you really got to get your vitamin D level up to the right level, and too high is not good. So we have different recommendations for what people's levels are. So, for example, in a patient recently, I gave him 50,000 units of vitamin D, which is usually a once weekly, like high dose prescription. Gave it to him every day for the first 3 days because we knew his vitamin D level was low going into it. We had to get it up in a hurry. And for people whose vitamin D levels are, you know, more toward the normal range, let's say 50 and 60, we have those patients taking 10,000 a day. So it is, you know, personalized based on their history with us. But there are many, many things that can be efficacious. I mean, certainly the antibiotics like doxycycline and zithromax can have an additive activity to these situations.
How about quercetin? Is quercetin still on the list? Is zinc still on the list?
They're on the list. The list is extensive. It's extensive. It's like a burdensome list, actually. It's like 15 things on the list. And the deal is I say, look, guess what? They may not all be working for you. But for 10 days, you know what I'm saying? For 10 days, I think it's worth taking a bunch of vitamins, a couple of antibiotics, some ivermectin, and go investigating into monoclonals. And we try to get packs of it. I've not been able to yet get it for my patients, but I did have a patient who got it through her connections. She's got a lot of connections in medicine, and she's a healthcare provider herself, and she was able to get it, and it did work well for her. And she's so, you know, she's the first patient that's been able to get it. And sadly, I didn't have clout to do it, but she was able to get it on her own. And so, but I hope, you know, in the next coming months, I mean, it's got to just be more and more accessible and easy to get, you know.
Yeah. Okay. I'm looking through a couple of questions. Okay. So here's a question from Bonnie Glick. How do I get the COVID vaccine out of my system if I'm having symptoms from it? I sure need some help with this. I've had a couple people ask me this over the last.
We're actually writing up a couple of cases now. One of my nurse practitioners has seen a couple of patients that came in with a diagnosis of chronic symptoms after the COVID vaccine, and they weren't sick before. One guy had a couple little minor symptoms he was going to the doctor about, but nothing major. And another person had no symptoms, and they both became chronically ill after the vaccine. Okay. And these people both had underlying undiagnosed, you know, in one case, relatively asymptomatic Bartonella, and in the second case had completely asymptomatic Bartonella. And they both responded to antibiotics exceptionally well and easy. You know, there's so much asymptomatic infection in the population. And I find that the people that they were kind of like, you know, their baseline status is that they're asymptomatically infected. When something upsets their immune system, be it a virus or immunologic stimulation like a vaccine or what have you, it's relatively easy to get them under control. Again, if reactivated infections is the cause of their illness. There's other debates about the vaccine, you know, which may have nothing to do with reactivated infections. And for that, I'm not sure what what the best course of action would be. From the perspective of infections, though, like I said, we want to write these cases up because these people were sick for months and months and months, and they went from doctor to doctor to doctor, and if a subset, if it, whatever that subset is, if it's 10%, 20%, it could be 80%. We don't know what that subset is. If there's a subset that you can like literally pull the thorn out of the lion's paw and get these people well quickly, just by recognizing that asymptomatic infections are common in the population with vector-borne illness, and people should know about it.
I'm not amused at all by the fact that Lyme seems to be obscured by EBV. It's like everybody's talking about reactivated EBV.
Yeah, and they don't really talk about the relationship of EBV with Lyme. So when Lyme bacteria get introduced into a cell that's latently infected, and latently infected means that the cell is like the EBV is kind of in hibernation. It's not actively replicating.
Mm-hmm.
Bubidorferi, the Lyme bacteria, actually induces EBV to start replicating again. So it is so silly to look at these things in a vacuum, but it's very, very hard because biologic systems are, by definition, these networked events. It's a tapestry, and it's hard because nobody likes to study these kind of interactomes that you need major computers for. It's much easier to study like one little thing at a time, like one linear thing. Like, hey, we found EBV associated with MS, and that means EBV causes MS. Okay, well, EBV is ubiquitous in the population, and something like in the high 90% of people have it. And what's another factor? What's another cofactor? I could just tell you from treating, I don't know, over 1,000 patients with MS at this point, and having very good outcomes. And we don't encourage patients with primary progressive MS because they don't have as good outcomes as relapsing MS. But our relapsing MS patients do really quite well in general.
I've heard from them over the years, and they have done incredibly well.
Okay. I mean, we've gotten a ton of them off disability completely. So I can't, and EBV is not going to respond to antibiotics. I mean, a lot of the things that we use now actually have antiviral overlap also anyway. Things like monolaurin actually work against EBV as well as all envelope viruses. But so many patients who had chronic herpes sores, and we started on monolaurin, and their herpes sores just like stop. And these are people who required Valtrex for years and years and years. Monolaurin is such a, I would say that it's like the humble chickpea. Monolaurin is like this little thing that, you wouldn't expect anything. And again, I don't like to oversell stuff because for some people it doesn't do anything. Like, you said monolaurin so great. Everyone has such a different outcome. Like, my third nurse practitioner is still in training now, and she's amazed by, like we all are, how differently everybody responds. And wouldn't it be nice to be able to provide some cookbook recipe that people can go by? But you really have to find out what works for each person, and go from there.
I have a good question from my friend Karen Donovan Mannion. Hi, Karen. Thoughts on enzymes like nattokinase and lumbrokinase? I can never say lumbrokinase. I think they are helpful with biofilm and reducing hypercoagulation. What do you think?
I think so too. So I take nattokinase and vitamin K27 every day. So, but I want to give caveats like I always do because of my ever so slightly obsessive tendencies. So people just know about nattokinase, where it comes from, the whole history about it, because it's really fascinating. So nattokinase comes from natto. Natto is fermented soybeans, and some people in Japan grow up eating this stuff. And it looks like Klingon food. I don't know if anybody ever watched Star Trek, but it's always like maggots with goo, and the Klingons are eating it, and the maggots are still living. And they say that that's what nattokinase looks like and maybe tastes like, whatever. But it's supposed to be super pungent. And if you didn't grow up eating it since you're like 2 years old, you couldn't possibly, eat it. Natto is Natto. And we should have the Natto challenge, like they have like the whole like whatever, the ice bucket challenge, like challenge people to eat natto. But but the chemicals in natto are so healthy, and I didn't mention that. So eating nanokinase, the people that eat the most nanokinase in Japan, it's only a subset. Not all of the traditional Japanese population eats natto, and some do and some don't. But the people eating a lot of natto have 25% lower rates of heart attacks and ischemic strokes, meaning clotting strokes.
Wow, that's incredible.
It is incredible considering that the traditional Japanese diet is already a very good diet for heart attacks and strokes. So they're like the primo of the primo. You're already getting such a great traditional Japanese diet.
Kind of like my mother's diet, it sounds like. Sorry.
What's that?
Sounds like my mother's diet.
Yeah, except minus the jelly donuts and
the Taco Bell
and the Danishes and what's the ice cream bars that she loves? The mint Klondike bars, yes, the mint.
I found out early in the pandemic what my mom and dad
Klondike bars. So right.
I found out when I was doing their Instacart orders in April 2020 what was really going on in the house. When she'd be crunching on something, I'd be like, "What is it? A carrot?" No, not a carrot.
Yeah, not a carrot.
Because when I went to order them organic stuff, right, with my Instacart stuff, I would upgrade all their food. She'd be like, "I'll have some chicken soup and some crackers." I get chicken. I'd upgrade to organic. She called me, "Ew, I hate the taste of organic food. It's disgusting." What are you talking about? You can't taste the difference. Like, it's not disgusting. You have to eat organic food. No. She
likes the taste of pesticides.
She likes chemicals.
Heavy on the chemicals. So back to nanokinase for a second. So nanokinase is natto in general. So natto has these really two good stuff in it. It has nanokinase and it has vitamin K27. Vitamin K27, I give in my patients, we give them broad recommendations to take it because it's really incredibly important, and it's just been well studied in the last few years. It controls calcium homeostasis in the body, like where calcium is going in the body, and it keeps it out of the arteries and into the bones. And it's where it's supposed to be. Calcium is not supposed to be depositing in our arteries and causing heart attacks and everything else. So you say, how well does it work in people? Keep in mind that when people eat natto in Japan, it's a lifestyle thing. They're doing it from they're very young to they're very old. So to do a 6-month trial in humans or in animals, you may not get the same results. So the data shows that they did a rodent study, and they showed that with normal doses of vitamin K27, if we just ignore nattokinase for a second, if they just give them vitamin K27, that there was not a statistical difference in the amount of calcification in the arteries at 6 months. But then if they gave them 20 times higher doses of vitamin K27, there was a whopping 50% reduction in the amount of calcification in the arteries. So I can't recommend to anyone to take 20 times higher dose of vitamin K27. I don't know that that's safe, but it does a proof of concept thing. Like if a more normal dose was given over a longer period of time, would it reduce calcifications? And they've done a human study where they showed that taking vitamin K27 at normal doses reduces calcifications at 6 months, but it didn't do so statistically significantly, but pretty close, and if it did it at that 6 months, if the study was twice as large, or if the study was twice as long, again, these people in Japan are eating it for 40 years and then they're getting less heart attacks when they're 50. It's not a 6-month trial. So I'm making it part, we have very unfortunately heart disease in the family. And, my brother Jeff died of a heart attack at 59. And I am choosing to make this part of my lifestyle. I take nattokinase and I take vitamin K27 every day. You say, what are the caveats? If someone's on Coumadin, also called warfarin, they can't take vitamin K because it will stop that from working. It'll basically counteract the effects of the blood thinner. Other blood thinners like Eliquis and things like this, vitamin K27 doesn't have an effect.
Okay.
People also ask the question, if they take vitamin K27 at a dose, will it increase the clotting risk? It's a good question.
Yeah, somebody is asking, actually Karen's asking that right now. Does Dr. P think vitamin K promotes clotting?
Right. There's no evidence that I've seen that vitamin K promotes clotting, just that vitamin K deficiency promotes bleeding. So that's good news. And then in terms of nattokinase, lumbrokinase, all those other ones, even though I've taken it, keep in mind my illness was so severe that I've been scanned up, down, and sideways a million times, for things like, every MRI you can imagine, for aneurysms, God forbid, and things like this. So, I am comforted by the fact that the people eat a lot of natto in those studies don't have increased risks of bleeding strokes. And I think that's great, because even things like taking baby aspirin increase the risks of bleeding into the brain. So we can look at a comparison that way and say, well, it's probably even safer than baby aspirin. However, it's still a blood thinner. And I know that, someone out there can take nanokinase or lumbar kinase or one of these blood thinners and bleed. And so I don't give recommendations on these programs. I just tell it like it is and say that there are risks to everything. And I can tell you what I'm doing personally for myself and what we're doing for my family and what I can tell my patients, but I can't give advice about, what folks should do. But there is a study out of China showing that nanokinase reduced the thickness of the carotid artery plaques that were happening. They did sonograms before and after and showed a reduction of the atherosclerotic process in the carotid arteries with nanokinase. And nanokinase also has a blood pressure lowering effect and has an effect on lowering cholesterol as well. It's not as strong as statins, but it's significant.
I got to start taking that. Honestly, I don't think I knew all of that. That's a lot of really, really helpful information. Okay, we need to whip through some questions because
I'm sorry. See, this is the thing. Like, I can spend an hour talking about natto.
Well, that's why we love you, because you give us really deep insights into things that most
I think it's all fascinating and so important. I wish we had I wish I had more energy to spend 3 hours on here. Everybody would be falling asleep, I think, at that point.
We have 20 minutes. So let's whip through some really great, we've got terrific questions, and I'm really excited about them, actually. Okay, so Kristen Marie has a great question. Mast cell activation syndrome and COVID discussion. Do you think the vaccine reduces your chances of long COVID? Well, we mentioned that there is a new study that says it reduces it by 50%. There are other studies that say it doesn't reduce it. If we take the 50%, that's I guess that is the more positive study. I don't think it's good enough to take risks personally indoors with shared air, because early treatments are still not widely available. Unfortunately, I was hoping we'd have a different conversation 2 years in. I was hoping that you'd be able to get Paxlovid the minute you tested positive, or monoclonals easily prophylactically if you need them. But unfortunately, we're not there yet. So my personal preference is to continue to avoid as much as we can wearing N95s, not sharing air, rapid tests before you socialize indoors. If you're going to do that, do help, I think, reduce risk. But okay, sorry, mast cell activation syndrome and COVID. What do you think about that? And are there any studies that you're aware of, and anything we can do to help?
So mast cell activation, the salient point that I have to say about that is that it's an effect, not a cause. Like, people look at it when they say mast cell activation syndrome. Mast cells are activated by something, So it's part of this kind of a type 2 immune response. We went over it in chronic, that chronic bacterial infections, for example, can induce mast cell activation, whereas a parasitic infection of any duration really is expert at inducing mast cell activation.
Yep.
And it's a whole rabbit hole to go down with parasitic infections. Like, I've referred umpteen patients to parasitologists because of findings that are not the stereotype. For example, let me just say, let's say somebody tests positive to Echinococcus. And Echinococcus is a parasite that people probably haven't heard of, and it can cause cysts in the organs, and we checked for cysts in the organs. Then the parasitologist said, well, we don't have to worry too much about Echinococcus. And they said, okay, well, what is Echinococcus doing? It's not causing the stuff that we're worried about. It's not causing the cysts. Is this a false positive test? And they say, well, maybe it's a false positive test. Okay, if it's not a false positive test, well, maybe it's reacting to a closely related parasite that won't cause cysts in the organs, but will just, live in the body. Okay, well, what's that doing? So we're getting this a lot. And I think that parasitology is really a super neglected field in the United States. And it's defaulted, to alternative medicine doctors and to naturopath and things like this. And everybody is just looking at stool tests. But, we now in the office, as part of the standard intake panel, we do a battery of just like Quest and LabCorp. We're not sending them out to fancy places. And we're getting about 20% of the people that we see are testing positive to these parasitic infections. And we treat the ones that we can treat, and the ones that are more complex, we're sending off to parasitologists. But we're getting, what's the word? Unsatisfactory responses. Like I'm getting a clear signal that there's a lack of expertise in this area.
Yeah.
And also a focus and kind of inappropriate focus on the stereotypes, like missing the forest for the trees. And cysticercosis is another one. People may not have heard of that one. You can get it from eating like undercooked meat and stuff. But they always think that if you don't have cysts in the brain, you don't develop neurocysticercosis, you don't have to worry about it. But none of my patients who tested positive for cysticercosis have had cysts in their brain. And now what do we do?
Right.
So we offer them treatments. We try to offer the best that we can. So when people have this diagnosis of mast cell activation, there's usually an occult, I believe, infection driving this. I'm not saying what that infection is, and I don't think there's specificity here. So can COVID do it? I personally seen it exacerbate mast cell activation tremendously in some patients. So I have seen that.
What do you think about LDN? So Tamara is asking about low LDN for long COVID. Do you think that's a reasonable?
I think it's certainly reasonable. First of all, I love LDN anyway because of its safety profile. It doesn't work for everybody. It works for, hi, Gerald. It's nice to hear from you. Live long and prosper. I hope you're a Star Trek fan like I am. So we use LDN quite a bit. If you look up the research in LDN, you'll think it's like the best thing since sliced bread because it's got a lot of published data behind it. It works about, I would say, 40% of patients, but because it is so safe and expensive, and when it does work, it can make a big, big difference in people's lives. I'm a fan, but I also don't keep people on it for some, what's the word, in perpetuity. I mean, we give like a 3-month trial. And the best people that do the best on it, believe it or not, are the people that hate it the most. People that flare up terribly on LDN because the mechanism by which LDN works. Because people don't really talk about like how it works. They just say LDN. No one really talks about what the mechanism. It blocks our own body's endorphins, these low-level narcotics that we produce on our own. And when you're exercising and when you're happy, you make endorphins. And LDN, it's like exercise and happiness in a bottle because it blocks the endorphins, and then so your body makes more. It thinks that we don't have enough, and it gives you the same effect as if you were like playing tennis every day and happy as a clam, even in these really tough times of the pandemic years. So.
Yep. Somebody said they really liked it, but it gave them heart palpitations. Have you heard of that before?
I haven't heard of side effects from the low doses that are used because they're like, depending on the doses, like 50% lower. I have seen certainly Trekkies Unite. I have, to me, sci-fi is like pizza. I will have a low threshold to liking science fiction, but like I'll eat cold pizza is what I'm saying. So so there are many, many things I've seen LDN flare up, just like there are many, many things that I've seen other immune potentiators flare up. And whenever anybody's dealing with heart palpitations, the first thing is to clarify the nature, because heart palpitations is not a medical term per se. It is and it isn't. It's not synonymous with arrhythmia. So I don't know if anyone knows about, and I have no financial relationship with this company, but if you're listening, KardioMobile, please start sending me checks because I have like half my patients, buy your app. So now 79. What's that?
That's true. That's true. I have one.
Because I really believe that this is an important thing. There are just certain things that everyone should have in the house in COVID times. One is a pulse oximeter. I mean, everyone should always have like a thermometer and the blood pressure cuff at home. Because when you page a doctor, your doctor wants to be able to tell you, go to the hospital, don't go to the hospital. They call vitals for a reason. They're vital. I mean, they can make the difference between giving you bad advice and good advice.
Yeah.
So basically a KardioMobile home EKG app. It does the same thing as an Apple Watch, but for like 1/10 the price basically, and it's $79 now. It went down another $10 on Amazon, and 2-day delivery, and you get a single lead EKG, and you can send the PDF to your doctor, and you can say send it during the time of the heart palpitations. I just recently had a patient who has had episodic, severe, we call them tachyarrhythmias, like really fast heart rate arrhythmias that were severe enough to go to the hospital on multiple occasions, and he couldn't get diagnosed ever. Nobody could figure out what he was because they wouldn't last long enough. By the time he went to the doctor or hospital, they would go away. And he got a cardiomobile, and he's got his diagnosis of now it's a supraventricular tachycardia, which is, usually a non-life-threatening arrhythmia, but it could be super disturbing and really difficult to go through. And there are ablations that are available for it, and people sometimes get them from Lyme. And
no, it's a great tool to have.
It's a great tool. So that, I guess in a nutshell, because I'm so wordy, is that for people who have heart palpitations, if they want to find out if they're, scary ones, not scary ones, during the period of the heart palpitations, yes, a full cardiac workup is always best, right? Getting a Holter monitor, getting an echocardiogram, going to the cardiologist, the whole thing. But if things miss it, because I hear this all the time, where people will wear a 24-hour Holter, and as soon as they take it off, they get the heart palpitations.
Yeah, I know.
And then some people will use them, for longer, like 2 weeks or even a month or something like this. But for people who get rare heart palpitations, you can miss it. And with the cardiomobile, it only takes a second to set up, and you can catch it. Anyway, that's the take-home message.
Okay, good. That's very helpful. Somebody, Sarah, shared that she used IV glutathione. I've heard this many, many times for vaccine, after taking the vaccine. And I've heard from many, many people, you and I both know, who had vaccine reactions, and IV glutathione helped them to feel a lot better. So that's something good to know. Somebody is asking if you could repeat the name of the drug. I lost where is it? Maybe you had said.
Oh, for endothelium?
Yes.
So I'm still unclear on it. I'm still unclear on it. So it was chondroitin sulfate, but not all chondroitin sulfate is equal. And first of all, like I've done some tweets on this, one of the primary, origins of chondroitin sulfate is animal-derived, bones, and there's risk for prions. Like the second most contagious part of the cow after the brain is the bones. So some places will.
Thank you for ruining bone broth for me. Go on.
Some places will have shark-derived cartilage, which they're thinking is, probably safer and things like this. But there's a vegetarian source of chondroitin, and there's different types of chondroitin. There's chondroitin 4, sulfate. There's chondroitin 6 sulfate, and it's seeming to me on this. They just had a study that came out where they reversed age-related cognitive decline in mice. They used a viral vector to change the. It gets complicated, but I'll make it. Sorry if I hope I don't lose anybody with the explanation. But do you ever wonder why people don't get, foreign accents until like you're 5 years old, you move to a country, and if you're below, let's say 5, you speak fluently and there's no accent. But if you come here or go there when you're like 9, you do. It's because the brain loses its ability to have neuroplasticity, and they figured out why that is. So it's not like the neurons change. There's these little, they're called perineural nets, and these little, they're made out of chondroitin sulfate of all things. And it's the specific features of the chondroitin sulfate are different. It's not all the same animal. So they just did this mouse study where they put this virus into the mouse brains to make them change the chondroitin sulfate from chondroitin 4 to chondroitin 6, and it restored their memory. And it induced neuroplasticity. So then the natural question that follows, if people supplement with chondroitin 6, would that be the same? I haven't yet. What I normally do is I usually, the biggest pain in the ass. I usually contact all these authors and ask them these questions. If I can't find out what I want to in regular PubMed searches, I send emails to the authors of these articles.
It's important. That's why.
Well, yeah, but because you have to be like a detective.
Yeah, it's great that you do that.
So, but you have to, if it's not, because a lot of scientists have private data that they haven't published yet, or maybe they're not going to publish it because they think it's boring, but it's actually really, really critical.
Yeah.
So, so I haven't done anything in terms of made recommendations about chondroitin yet, but there is some heart disease data which has not been followed up on, showing that there was a very material reduction in heart attacks in people who were taking chondroitin for osteoarthritis.
Okay.
So that's, I think, where we came to the question about how does it repair the endothelium? And I believe that it does, but I don't want people, taking the wrong kind of chondroitin and then maybe risking cognitive decline because it's
Don't
something
worry.
with these perineural nets. Do you know what I'm saying?
Do
So
not
this
worry.
it's a complex topic, and I've been investigating the reversal of dementing illness for a while now, and I've become acutely, more interested in it lately. And it's a whole nother several Facebook lives to talk about it, because it really is fascinating. I've seen some case reports of remarkable turnarounds, and before this, really, it was very, very. It's the most difficult group of patients to treat. Really, is the neurodegenerative ones. So.
Very, very interesting. You have done quite a bit of writing and research, and we should do more. We should just do a talk one night about that, and maybe we could get David Perlmutter to come on and speak with us too, because
yeah, definitely, I love David. Yes,
I learned a lot from him, and he's a fabulous. You might know him because he wrote Grain Brain, and he's a fabulous neurologist. He's very open-minded, and he's landed on a lot of things before it became popular. Before he made a lot of interesting things mainstream. The last question before we go is people are asking about tinnitus. Okay, tinnitus recommendations. We could do that last, and neurologic Lyme and herbs. I know for me, artemisinin was very helpful. Oil of oregano was helpful. Hadatonea. I actually have a bottle someplace around me, but I could try to grab it and just show people because it's really hard to spell. Those are 3 things that helped me, and also garlic. So
right.
anything? Did I miss any big ones? Cat's claw.
Yeah, there's so many big ones. The problem is that they're trial and error, like the antibiotics are trial and error. And I always tell my patients that we are absolutely not in the herb business. After seeing myself personally 25 doctors, I went to so many doctors, and some of them were functional medicine doctors, and I'd buy the 5 herbs, and I'd say they're not helping, and they'd say, okay, stay on those 5 and buy 5 more. Like what I do when we do herbs, I use them as single variable change. I say, here, try this before, like 4 days before starting something. If you get a Herxheimer, if it's obviously impactful, we'll take that as a good sign, and maybe it's worthwhile continuing. If it's not, I have like a very short attention span for things that aren't covered by insurance. Because you could put that money elsewhere. I always think of like how many toaster ovens can this buy. I equate everything to toaster ovens because I didn't really grow up with any money or anything. And I'd rather my patients, spend their money kind of wisely, because I've had patients in the last year that have come in on $1,500 a month herb bills as new patients.
That's terrible.
And I've been just blown away. I was like, how did this happen?
Yeah.
I'm not anti-herb at all. Like I'm pro things that work, and I'm also pro being frugal and putting that money. Like what I really, really want is for my patients to get better and save that money and have an amazing trip to Rome or whatever, than wasting. Like things can be done judiciously. We can find out which ones work and which ones don't work, and then you develop like what I call it the arsenal. You get your tools. Like what works for you. I know what works for me. Unfortunately, I don't respond to many herbs. The only ones that I responded to were liposomal artemisinin, oil of oregano, and monolaurin. And I've tried them all. But I have patients that respond better to herbs literally than they do to antibiotics.
Yeah.
And of course, I'm like so jealous. But they respond with huge Herxheimers and stuff that, a drop that will flare them up and then give them better. I take like a whole bottle and nothing happens. But again, it's just evidence of how different people respond. But if I had to say, the combination of cryptolepsis and Japanese knotweed is a good combo that was tested at Johns Hopkins, and we didn't mention that. And cemento is always tried and true. And sarsaparilla, even though people don't talk about it, and teasel, because these are old school.
I like sarsaparilla a lot. I thought it was really helpful.
Yeah, they sometimes help my patients. And andrographis helps a lot of folks too, but we have to be tricky because some people get allergic to it, and you can get rashes on it, and who knows, it could be more serious allergies. I haven't seen more serious allergies than that, but I've seen some rashes.
I love andrographis because it also prevents a lot of colds and stuff. I take it. My acupuncturist gives it to me, and I've been taking it for years. I feel like I'm coming down with something.
Yeah.
And I like it. It's like a main ingredient in cold away, which I like, which is by health concerns. I'm looking at all
And
my.
coptis is a big ingredient in that too, in cold away.
Yep. Yep.
So the thing that I do warn people about herbs, though, aside from trying not to like just, take a million herbs that if you're not sure they're working, the other thing is, unfortunately, it could be, and I was doing this when I was at my sickest because I was buying herbs on Amazon in the middle of the night, and I was buying the cheapest brands. So I figured, oh, they're all the same. And then I looked at these exposés looking at heavy metal content of various herbs.
Yeah.
It doesn't pay to get the cheapest herbs. I'm not saying people have to get the most expensive either, but something middle of the road, there's a big difference between the level of contaminants, because a lot of these herbs are coming from abroad. They're coming from China and other places. And if you get the cheapest of the cheap herbs for things that are synthetic, like maybe, vitamin C or whatever, I think it's less vitamin D. It's less of a concern. But for the herbs, I would not get the cheapest brands out there.
I agree. I have those concerns. Okay, the last question, and then we have to go, is do you have any strategies to improve tinnitus? And this is for Lyme and COVID. We're getting questions for both, and high pitched. Somebody's asking for a husband. Somebody's asking for COVID, post-COVID stuff.
There are a lot of things that. Okay, so in terms of a post-COVID world, we have to do detective work to find out. Like I said, is it coagulopathy going up? Tinnitus can be microvascular. Tinnitus can be neurologic. Tinnitus can be lots and lots of things. So a lot of my patients that never had COVID have had horrible problems with tinnitus, and they can respond to antimicrobials. As a general rule, magnesium is very, very healthy to the ears. They've done, rodent studies where they've done, shotgun blasts or some type of gunfire blast next to the ear of some type of rodent, and show that the ones that took magnesium, even with a delay, they don't go deaf, but the ones that didn't get magnesium go deaf. So magnesium has some crazy quality to it that it's otoprotective. It's protective to the ear nerves. Okay. And so that is my one general, go-to for people with ear stuff. But really, there's not a single, people talk about these bioflavonoid preparations of some like herbal remedies directed toward tinnitus. I've never been too impressed with them. I have it. I don't want to seem like that's a cop out, but it's really, really heterogeneous. I mean, some patients, I can tell you the things to look for that are maybe warning signs that people get pulsatile tinnitus. They have to be worked up by the neurologist. Having said that, because pulsatile tinnitus can sometimes be associated with aneurysms. Tinnitus, when it remains one-sided, is generally more of a concern than when it's bilateral in terms of things like acoustic neuromas, which can cause, they're usually benign because the neuroma is almost always benign, but they are tumors that can form. So if people get pulsatile and unilateral tinnitus, it's a reason to go quicker to an ENT. And really, I think just as a general course, it's good to get a once over by the ENT for tinnitus first. If they can't find anything, then we try to do the sleuth work, the detective work to find out if someone's had COVID, if they have, at Quest, they actually have this post-COVID coagulation panel now. Huh. Not a lot of components in it. It's like D-dimer, like fibrinogen or something. But it's just shocking to me how many people are having these elevated D-dimers after COVID.
It is shocking. And young people, it is shocking. I was reading a little bit about tinnitus recently, and there are like different kinds of headphones that can cancel out the kind of pitch and sound, and there are different things that you can do. If people are suffering from it, it's very, very stressful symptom, especially when it's constant, and I get it. So I would just say do some diligence on this kind of other, I haven't found that there are a lot of treatments, except time, that seem to work. Dr. Phillips just pointed out magnesium. That's a great suggestion. A lot of people will just say it will go away over time, but also there are these things you can do to sort of bring down the level of torture and torment while you're going through it. And I would look at like biofeedback, there's just different things that I've read about. I would Google around, and if I find anything amazing, I'll post it.
Even low-dose antidepressants can be helpful. Yeah. Again, I'm not the big fan of suppressing symptoms, and I want to get at the cause. But they're not mutually exclusive. You can have people so they don't suffer as much. But I know ENT doctors using some things like SSRIs, like Zoloft and stuff sometimes to reduce the effects of it. And it's not in the book, but you know, my patients know, or the ones I've spoken to about it. But I've lost significant hearing about 5 times when I was at my worst, and one time it was like 80% hearing loss in my left ear. And I've had a million hearing tests, and I have like ears like a bat. And you know, I just pounded the antibiotics during that time. And the traditional thing for, because it is important, I think, to talk about. Um, you know, whenever the subject of tinnitus comes up, I want to always touch on acute sensory neural hearing loss because I've seen it in my patients. And the ones that I've seen that have had that, meaning like they wake up deaf one day, the people that did not know that infections could play a role, like the standard treatment is steroids. And I don't withhold steroids for my patients who have that. I'd say, go to the ENT doctor, get your steroids, and I'm going to offer you a bunch of antibiotics on top of that. Because the spontaneous remission rate, the spontaneous normalization rate is like 50%. And yet all my patients that have been treated either with steroids, and some of them didn't actually take the steroids because they were nervous about taking them, but I was not advising not to take them. I advise them to do everything that the ENT doctor says, plus I'm going to treat you with X, Y, and Z antibiotics. All my patients have gotten their hearing back. And this has happened over 25 years. So that says that we should treat, you know, sudden sensory neural hearing loss aggressively. And again, I'm not the doctor to call if it were to happen to a person, because we can't accept patients the day that they call, and this is an emergency. You know, this is like, but people should be demanding, you know, I guess that the ENT doctors become, you know, up on this, and because it's not something that the ENT doctors are offering; they're just offering the steroids.
Right. That's true. So. That's true. Okay. Well, I am glad that we got to get all this in this last hour and 7 minutes. Let's do these more.
Yeah, we have to do these more. I miss doing this because, you know, we're seeing great patients. You know, one of the things that telemedicine has done is opened up the practice to patients from, you know, far and wide. Yep. And we're going to be starting to see patients in the backyard again when it's warmer. You know, it's just...
I get a lot of messages from people asking me, I don't know why they come to me, but they come to me and say, well, doctor, is the practice taking new patients? So
yeah, we're taking the patients.
I always say, did you ever try to call? No, no one tries to call. Everybody's afraid to call.
No, we get 400 phone calls a day. I mean, I don't think one more is going to hurt. You know.
well, I know, and I don't work for your office, so there's like this impression that I know what's going on day to day. I know that you guys are always busy, but I also know that you make huge efforts to get in patients who need to see you. So you don't have to ask me. Just give the office call if you want to see Dr. Phillips and his staff, and they'll fill you in on what is possible. So
I'm very, very lucky to have an office that I do, I have to say. I mean, it really runs very smoothly, and it's so I'm just count myself very fortunate that the office runs smoothly. So.
I count myself fortunate that it does too, and for all of you, because you guys help so many people, and including me and many of my loved ones and friends and family, and people who have become my loved ones because they've been your patients, and I've become friends with them over the years because, you know, we all bond over this comment.
I know. It's so crazy how out of dark stuff comes so many good things too.
I know. We used to talk about that with Neil all the time. It's like, there's nothing good about Lyme except that we all got to meet each other. You know, we all got to become really, really close. And like, I don't know another way that our lives would have intercepted in these.
You never know. I could have had a skyrocketing music career. I mean, you just could have, you know, I would have been just at a gig one day. I would have been there.
That's totally true. Or I could have come up and decided to be.
I would have had to get hair transplants to do that.
Would you say?
I would have had to have gotten hair transplants to do that.
That's not necessarily true. Phil Collins, for example.
Right.
You know, there are some handsome, cool, balding rock stars that have been in business.
I agree. There's nothing cooler than a balding rock star.
You know what? I don't notice these things. I notice raw talent, baby. And you got it. So
thank you.
It was great to see you, Steve.
Nice to see you as well.
We get to talk a lot, but we don't get to see each other enough. And it's like really bumming me out. So I'll be back east soon. I'm hoping and praying that.
Let's thank everybody for joining. We appreciate you guys so much. Thank you for tuning in. I know that everyone has busy lives, and it's a privilege, really, to spend time with everyone. You know, it really is. So
thank you. And our paperback is out. Please buy it. It is at Barnes & Noble, Target, Walmart, everywhere books
wherever
are sold.
fine books are sold. My thing is, please share it. That's what I always say. I always because I am still amazed. It's not just a salesy kind of a thing. I am still amazed by how this is helping people and how it's doing what it was designed to do. We get calls to this day of people who are not our patients, who don't need appointments, and they're seriously just saying thank you. And it's like the best medicine for me anyway. Is to say that the book is helping people in a way that we kind of envisioned that it could. And it's done that. It's really been a blessing, you know.
It has, and I feel the same way. And I've saved all the messages and compiled screenshots of all the wonderful letters and comments and stuff that we've gotten, and it fuels me, because it's kind of lonely being us sometimes, like, you know, outspoken, going against the grain. We get a lot of pushback, and then at the end of the day, if we're helping people, I don't care. I can go up against it. I feel really
something about being betrayed by the medical system and almost dying of mystery illnesses that makes you not give a crap.
I agree. So anyway, on that note, it was great. On that happy note, it was great to be with all of you. Thank you for your questions. Thank you for your support. We'll be back soon.
Okay. Good night, everybody. Be well. Talk soon. Okay, bye.